And this morning, we're very pleased and privileged to have a very eminent speaker together with us for this next extension of the SK Dharmalingam lecture series. And as you know, SK Dharmalingam lecture series is organized by the National Cancer Society of Malaysia, and it's about creating awareness pertaining to different topics on cancer, including how we diagnose different cancers and we treat them. So we've always been very privileged and honored to have with us eminent physicians, surgeons, consultants who have been willing and very generous with sharing their expertise so that we can help in educating our fellow colleagues in order to do much better at kind of curtailing, controlling this horrible disease that we now have within us called cancer. As you know, March was Colorectal Cancer Awareness Month. And I think, and I'm sure the first question is going to be, what are we doing in April with colorectal cancer? And I think this is a very apt kind of reminder that for a lot of people, colorectal cancer in their minds ends with March. And I think one of the important messages that our presenter and speaker will go on to strengthen today is the fact that colorectal cancer is an ongoing thing. It's not only March. March is basically is where we rah-rah and create a lot of noise. But I think it's something that you need to look for within your practices throughout the entire year onto every patient that walks through your door. So to give us this message and give us a lot more insights and updates onto colorectal cancer, I am very privileged to be able to introduce Dr. Ragu Ramasamy. Good morning, Doc. Thank you for joining us. Dr. Ragu's on mute, I think, Doctor.
Hi, morning, Murali. Thank you for having me here. It's such a privilege to be with you guys and to be able to present and to create this awareness. I know it's been a week, it should have been a week before, and due to unforeseen circumstances, I have to delay it. And but still, like you said, this is an ongoing thing. It's not just a March, so we hope to create this awareness throughout the year and forever. So absolutely. Thank you for having me.
Doc. Absolutely. And ladies and gentlemen, Dr. Ragu is a consultant general and colorectal surgeon. So he's primarily the person who picks up the abnormalities then that we kind of finally realize is colorectal cancer. And as always, colorectal surgeons have a very important message to share on the fact that this is one of the cancers that really you can pick up at stage 0. Anyway, so please allow me to turn the stage over to Dr. Ragu, who will speak to us about colorectal cancer. As usual, if you have any questions, drop them into the question and the chat box, and we can field them together. So over to you, Doc.
Hi, thank you. So I'll share my screen now. Okay, so I hope everybody is seeing this.
Yes, Doc, clear, and we can hear you well as well.
All right. Okay, thank you, and good morning, everyone. It's been a privilege to be invited by the National Cancer Society of Malaysia to present this on a topic today morning on colorectal cancer. As you know, colorectal cancer has been on an increasing trend throughout Malaysia and the world. And we are seeing more and more colorectal cancer. As I started about 10-15 years ago, and I've seen more. It is not generally a disease of the old age. It is becoming more common in the younger population. So there are a few messages that I just would like to convey. I just keep it simple on a Sunday morning so that everybody could understand what I'm going through. So I have no disclosure for this presentation in my outline. So since we have broken this into 2 sessions, as Murali there is a break in between. So in the first session, I'm just going to make a brief introduction of the incidence of colorectal cancer and colorectal cancer in Malaysian perspective and the global perspective. And in the session 2, we will be going to screening for colorectal cancer, which is one of the most important thing I think I want to talk about today here, because most of you just want to hear in general about the colorectal cancer management, because this is done by colorectal surgeons and the tertiary care center. So I would just briefly go through the colorectal cancer management on that side. So as you know, colorectal cancer, it's the commonest cancer in Malaysia among men. Age standardized incidence about 15 per 100,000, and second most common cancer among Malaysian women. If you take this in general, this statistics was published in 2016. Colorectal cancer is the second most common cancer in Malaysia. The overall incidence of colorectal cancer is 21.3 cases per 100,000 population. In an age-adjusted incident rate was 1.33 times higher among male compared to female. So always people ask me, doctor, is it just generally a disease of the male? No, it is also very common among the women and second most common among the women. And we should be aware women could also get this in the younger age, although it's common in the older age. So I would say this 1.33 times is not much higher among men compared to the women. The incidence was found to be highest among Chinese, followed by Malaysia, Malays, and Indian. Among the Chinese, there was a study done also in the US where the Chinese who migrated and came to US, and they found that when they have adjusted their food and their lifestyle, still there is quite common among the Chinese. Maybe there is a genetic predisposition for them. And the overall mortality is about 10 cases per 100,000 population, and age-adjusted mortality rate was still common among male compared to female. This is found that male has a higher body size, male also has a narrower pelvis, male tend to present in a, making this quite difficult to do surgery among male, and also male tend to present at the later stage compared to the female. About 66% of male and 65% of female present at the later stage. Overall, about 70 to 80% of Malaysians generally present in a late stage. This is why I think we are doing this colorectal cancer awareness. And one of the most important people is like GPs like yourself, who should be aware and have a very low threshold. I have a group of GPs that I talk to usually, and I always say, please have a very low threshold in trying to assess this patient for colorectal cancer. Because currently, I would always say this statement that in 1970s, if my father or my great-grandfather presented with per-rectal bleeding or abdominal symptoms, I would have just taken it as a gastritis or colitis and hemorrhoids and just leave it. But in year 2020s, we can't. One is because the cancer rate is increasing. Second is also medical legal practice. So we don't want to treat them and 6 months later. I recently had one practitioner who sent to me what was the patient was with them was about 6 months to 1 year with per-rectal bleeding and was treated as hemorrhoid, but when one was sent, the cancer was just situated about 2 to 3 centimeters from the anal verge, which is something could have been done when only if a PR was done for this patient. So late presentations mainly partly due to low cancer awareness and misbelief about cancer. So this is one of the things that we found among Malaysians. So this is one of the studies. They look at the socio-demographic of the patients who present with symptoms and anticipated delay in help seeking in multi-ethnic Asian population. They found that very alarming that 40.6, about 40% of 2,000 plus participants recognize blood in stool as warning sign. So this is something that alarming. I think a lot of them will dismiss this as just hemorrhoids, boise. A lot of them will just say boise and they just leave it. And sometimes it gets better, so they leave it for a longer time. And most of the causes they found during this time was in this paper is one is denial, negative perception of the disease, over-reliance of traditional medication. A lot of them go on to buy traditional medication and try all kind of things before they seek treatment. And misperceived risk, whereby they actually think that this is something very benign. They don't have to have a look at it, so they feel it is okay. And emotional barriers. emotional barriers and negative perception towards the screening itself is causing a lot of problem in these patients. So I hope we as clinicians will just be more aware of these problems. So is colorectal cancer increasing trend in Malaysia? Yes. This is a paper that was published by Malaysians itself. They did about 14,000 cases, and they found that a 5-year trend showing an increasing trend for both genders among Malaysians. So this was in 2012. So I think as 2022, there will be a lot more cases. So let's look at why the increase. If you look at most of the papers, they will say improving socioeconomic status and increasing westernized lifestyle. That means our diet. Diet plays a lot of importance in colorectal cancer. And this one of the papers they found that including Malaysia, there's a westernized lifestyle that could be associated with the increasing incidence of colorectal cancer. Another factor is Malaysia is aging. About 80% of colorectal cancer in Malaysia are people older than 50 years and above. The aging trend, that means that aging population and aging trend may further increase this prevalence. And we are seeing patients, and I'm seeing patients who are at 70s and 80s are coming with colorectal cancer. So as our life expectancy, I think we are increasing, we are getting better at it. So we will see more among the older disease. And one of the reasons that I find is that we miss them. We miss them at the age of 50, whereby some form of screening should have been done for them, where they missed it. So they present later on in their age with colorectal cancer. And let's look at the tumor statistics. About 80% is at the left-sided, and majority are at stage 3 and 4. And only about less than 10% of Malaysian colorectal cancers are diagnosed in stage 1. This is something that we all should be able to do something about this. That's what we are talking about today. So if you look at this slide, I just want you to to highlight. If you look at this and the yellow and also the red, the cost of treating a stage 1 patient, let's say it's about 4 million. And the cost of treating about these patients who are stage 4, it is 10 times more. All right, so it is very expensive when the patient comes at the late stage. That means in our country, whereby we don't have a programmatic screening, we are going towards opportunistic screening. At the end of the day, we are paying more for treatment of these patients, because it's not only surgical treatment, then we are also going to oncological management, which are very expensive for this patient. So now that I've highlighted is increasing in Malaysia, so let's look about around the world. This is one of the studies that was presented in GUT 2017. They look at the global pattern and trend in colorectal cancer incidence and mortality. So they found that around the world, 3rd most commonly diagnosed malignancy and the 4th leading cause of cancer death around the world, which account for 1.4 million new cases and 700 deaths in 2012. This is something that I found that very alarming. One of the statements that was made in this paper, and also by one of the very prominent cancer research person in America, that this global burden of colorectal cancer is expected to increase by 60%, which is more than 2.2 million new cases and 1.1 million deaths by 2030. This is an alarming statement. In the same paper, they identified 3 patterns of colorectal incidence and mortality trends. If you look at certain countries, they have very high human development index. All right, so with these countries, if you look at it, increase in both incidence and mortality in rapidly transitioning countries which are growing very fast and adapting a lot of westernized lifestyle, and they also have a very high human development index. And countries like these, if you look at it, one of the country they looked at, even Brazil, they looked at Philippines. If you look at it, the colorectal cancer was increasing, but the mortality rate was also increasing among these people. So this is one of the things that they found. Another pattern of colorectal cancer was increase in incidence with concomitant decrease in mortality. This is found in very high development index countries like Canada, UK, Denmark, and Singapore. I just want to highlight here in Singapore, if you look at it, there is an increase, but the mortality rate is decreasing. The incidence is slight increase, but the mortality rate is decreasing. Sorry. But there is another pattern whereby there is decrease both the incidence and mortality. This is countries which have the highest human development index countries, including USA, Japan, and France. So if you look at Australia, I just wanted to highlight here, the pattern is decreasing in the incidence. But if you look at the mortality, it's reducing a lot. And even the USA, among the black and the white, if you look at it, the statistics shows the incidence is decreasing. But the good thing is, and also the mortality among these people are decreasing. So why is it so that we can find these countries where there is a decreasing in the incidence of cancer and also decrease in mortality? That's what one of the most important things that I want to highlight here. I think it is early detection and improving the survival. So even if we are going to develop this cancer, if we develop it early, we are trying to decrease the mortality from this cancer. This is an important thing that we should all be aware by doing the screening. So early detection, this will improve the survival. This is what we're going to do. So how can we make this happen in our country? So let's revisit some of the basics of colorectal cancer. How does it develop and why is it so? So let's look at the origin, early symptoms, and the screenings. As you know, most of this cancer, 90% of the cancer is sporadic. Colorectal cancer is sporadic. Only about less than 10% is hereditary. That means all the people, all the patients that comes to us, it always assume that I don't have family history of cancer. I do not have any symptoms. Why should I be worried about colorectal cancer? This is why this is something that we should be educating them that 90% is sporadic and anyone can get it. This is a pie chart whereby the sporadic case, if you look at it, is most of the time. So how does colorectal cancer develop? This is one of the famous ones, is adenoma carcinoma sequence. This is one of the reasons why we are doing screening is because we want to look at polyps. Most of these cancers will develop from polyp, and from a normal epithelium to become a colorectal cancer, it takes up to 10 years. So we are given 10 years window frame. That means as a doctor, as a colorectal surgeon, as anyone who's handling healthcare, we are given this opportunity to advise these patients to do something about colorectal cancer. But if they miss this boat and develop into a cancer, then the treatment becomes different. So another pattern of development is microsatellite instability, very complex pathway. Another pathway that the colorectal cancer develop is a CPG, island methylator phenotype. It's another complex pathway. Let's look at the hereditary syndromes. One of the most famous that everyone would have heard is the familial adenomatosis polyposis coli, whereby this family will surely develop cancer. If we don't catch them by 12, they will develop cancer by 20. So most of these patients will end up having their colon removed. So this is a very famous one. But we also have Lynch syndrome, we got Peutz-Jeghers syndrome, and hamartomatous polyposis syndrome. So what are the syndromic familial risks is FAP, this is autosomal dominant, and hereditary non-polyposis colorectal cancer. This is another important part of this presentation, whereby these HNPCC patients are autosomal dominant transmission is the most common form of familial colorectal cancer. They are associated with also breast cancers, ovarian cancers. So we must also look at this pattern in their family. And these patients, usually there is an Amsterdam 2-3 criteria for HNPCC, whereby they have family. And at least 3 of the relatives have this HNPCC related cancer. If you can see here, they also have endometrial cancer, stomach cancers, renal, biliary, and also small intestinal cancer, they must be first degree relative. At least one of them must be first degree relative of the other two. At least 2 successive generations are affected, and they must be diagnosed before 50 years old, because we are assuming whatever developed after 50 years old is always associated with old age cancers. So less than 50 years old. So this is HNPCC. If you are looking at patients who come to clinic, so we should be able to assess them when they say they have cancers, whether they are associated with HNPCC, then they might have higher risk than the normal population to develop colorectal cancer. So these are the patients which we want to send them for screening earlier. Another thing that people always ask, early symptoms. Even we should be educating this to our patients, whereby early symptoms are never early enough. This is something that I always want to highlight, whereby these patients, when they present to us with early symptoms, there's already a symptom. That means they already have some form of this cancer. But why wait? Why should we wait for them to have this problem, like altered bowel habit, rectal bleeding, abdominal pain, loss of weight, loss of appetite, anemia, and obstruction? This means even if patients coming to you with an obstruction, it's already very late. So when the patient tells us that they do not have symptoms, that we always say, please do screening before you have symptoms. Or if you have symptoms, it's not screening anymore. So it defeats the purpose. So I think I'll just conclude my part 1 of the presentation for the colorectal cancer today. I just want to highlight here that the high incidence of colorectal cancers in Malaysia with late stage affects nearly equal, I would say, both men and women. There is an increasing trend of colorectal cancer among Malaysians, be it men or women, and also younger population. Many patients who are presenting nowadays, I've seen age of 33, 20s, 40s. So there are many patients who are coming with the earlier stage. So we should be aware of this. And more than 90% are sporadic. So they do not have family symptoms or familial predisposition. So we do not ask them this. Early symptoms are never early enough. So these are the parts that I just wanted to highlight in my part 1 of my presentation. So so we will back to Dr. Murali for now before we go on to the part 2.
Dr. Ragu, please continue, Dr. Ragu.
I think I will continue with the part 2. Okay, maybe I can. Yeah. Maybe I can sambung. Wait.
We are going on, yeah, with the second part.
No.
Yes,
Yeah.
we will continue until that time.
So can I continue? Hi everyone. Sorry, I think the Murali has some computer glitch with this part on his part there. So I will continue with my second part. So this part 2, we will both basically will be looking at screening and updates on colorectal cancer surgical management. So I am sure all of you have heard about the word screening, and there is 2 types of screening we should be looking at. One is programmatic screening, and the second part is an opportunistic screening. What is a programmatic screening? This is a countrywide or system-wide organized approach. That means when you are 50 years old, when somebody is sending a form, fill up this, either do a fecal occult blood test, or please go for colonoscopy when it's positive. So this is a system-wide, country-wide organized approach. There are many countries, especially European countries, Australia, and all that, that's adapted to this form of system-wide organized approach. And there is something called opportunistic screening. I think in our country, basically what we are doing is more like an opportunistic screening, whereby the healthcare providers themselves offer to the patient. We offer them at least multiple options to start the screening. We can either offer them a fecal occult blood test, or we can offer them a colonoscopy straight. So this is something that we as a clinicians, we should be aware when and why, and who are at risk and when should we send them. So is there evidence to support screening, and does it reduce mortality? Yes. I am not looking at the financial part of the screening. Most of the papers have looked at the financial part, whereby when they do a screening, the detection rate is low, so the financial cost is small, so they do not offer this in certain countries. So, but we are looking at this, there evidence, and does it reduce mortality? Yes. So this is one of the papers that was done to look at the effect of fecal occult blood test screening. This was an American paper done in Minnesota colorectal cancer control study for 18 years. More than 40,000 patients was included. In this conclusion, they did that is that the use of either annual or biannual fecal occult blood testing significantly reduced the incidence of colorectal cancer. The most possible explanation, they found that identification and removal of precursor lesion, which is polyps. So this is very important. So that's why we should have a low threshold to do a colonoscopy. So this is the graph that was shown in that paper. If you look at it, this is a control group, and these two are either an annual or biannual screening group. So the incidence have reduced when you do at least an annual, or if not a biannual screening for these patients. This is another one, Cochrane systematic review that was done for colorectal cancer by a fecal occult blood test, which is HemoCult. They did an update, which published quite some time ago, and screening had a 16% reduction of the relative risk of colorectal cancer mortality, and 15% reduction in colorectal cancer mortalities with biannual screening, and 25% attending at least one using the fecal occult blood test. There's another paper that was published in Clinicals of Colorectal Cancer in 2017. They found that GOI-based fecal occult blood testing reduces the colorectal cancer-related mortality by 15%. This is significant. So basically, we are looking at reducing the mortality rate by doing the screening for these patients. So we have multiple types of fecal occult blood tests, can be done yearly. Stool DNA test 3 yearly, CT colonography can be done 5 yearly, and colonoscopy up to 10 yearly. So let's look at fecal immunohistochemical tests. A meta-analysis shows that the studies that evaluated the diagnostic accuracy of FIT for colorectal cancer in average risk patients found that the sensitivity and specificity to be about 80% and 94% respectively. Compared to guaiac-based, the fecal immunohistochemical detects human globin. So currently, when we do this kind of test, we don't have to ask the patient to do a dietary modification. Makes it easier for them, and single testing sample is sufficient for these patients. This is looking at FIT again. Non-randomized studies have shown that FIT screening reduces the colorectal cancer mortality. And one of the paper which was done in Taiwan, with a maximum follow-up of 6 years, there was a 10% decrease in colorectal mortality was seen in FIT screen population. So it ranges from 10 to 15% if we are screening these patients, a reduction in colorectal cancer mortality rate. So this is important. So what are the methods that we using, FIT or CT colonography? CT colonography is a useful test as high specificity but heterogeneous in the sensitivity. It has to detect at least a polyp, which is more than 1 cm, which is more than 10 mm. So it has to be big enough for them to detect that. But if it's anything smaller than that, CT colonography has not much use for these patients. And another disadvantage of CT colonography is that repeated exposure to ionizing radiation. And many countries are studying the MR colonography for detection of colonic polyp. In our country, I feel that this is something difficult to adapt because MR is not available easily, and even the private hospitals sometimes have one. If you look at their list, it's quite long. So this is something that might not be available for some time. And another drawback about doing a CT colonography is that if you detect polyp, this is by NCCN guideline, if you detect polyp, it all goes back again to colonoscopy. So basically, we are subjecting these patients mostly for radiation, and then we come back to colonoscopy. So I feel that CT colonography, and I always do CT colonography in patients who are not fit for colonoscopy. They have very high risk, and patients who sometimes once or twice a year, when we do colonoscopy and we find that very difficult angulation, unable to reach the cecum, and some of these patients, CT colonography can be useful. So we come back to colonoscopy. The colonoscopy is still the current gold standard. I use a lot of colonoscopy even for detection. The advantage of doing colonoscopy is that it is both diagnostic and therapeutic. That means by doing colonoscopy, we are not only looking at the polyp, but we can also remove the polyp. So this is one as shown to reduce the mortality from colorectal cancer. So if we go on doing the CT colonography, we might come back to colonoscopy. So that's why I skip the CT colonography to colonoscopy straight. If not, I will just go to fecal occult blood test. These patients who are not interested, very low risk for colorectal cancer, I would at least advise them to do a fecal occult blood test. So this is another study, protection from colorectal cancer after colonoscopy, a population-based case control small studies that was done that showed that colonoscopy in the preceding 10 years was associated with an overall 77% decreased risk of colorectal cancer. And by doing colonoscopy and removing the polyp was associated with 53% reduction in colorectal cancer mortality in another paper. So one of the important questions that patient always, we have to tell the patient is that, of course, there is a risk of doing colonoscopy. Colonoscopy is, I would say, is more invasive, whereby we have to sedate the patient. Sedation risk is there. Secondly, we are doing a procedure. This procedure is associated with a low risk of bleeding and low risk of perforation. I will always say it's less than 1%, and most of the time it is done by expert hand. This risk is negligible. So nowadays a lot of colonoscopy is being done, and you will hear very rarely and we don't want to hear about perforation. But of course, the risk of bleeding, especially patients who are on NSAIDs. So NSAIDs, we have a lot of old patients who come with the cardiovascular disease on NSAIDs. The patients are always on, not NSAID, I mean aspirin. Patients always on Plavix. These kind of patients have a higher risk of bleeding. Sometimes we have to stop the Plavix or the aspirin or cardioprin. Although the British guideline says that in a patients who we do not do major procedures in colonoscopy, we don't have to, but still the risk is a risk, and if can, I normally hold the aspirin or cardioprin or Plavix before I do this procedure, because sometimes when I find big polyp, I still cut it. So colonoscopy, I would say, still the gold standard in doing in screening. If patient with a very low risk just walks into the clinic, you can still do a fecal occult blood test for these patients. If they are positive, we can send them for colonoscopy. But if I perceive they have a higher risk, I'll always do a colonoscopy first. And if the patient has or cannot complete the colonoscopy or very high risk for colonoscopy, then I would suggest them at least do either fecal occult blood test or CT colonography. So who should be screened? This is Malaysian guideline published 2018 by Colorectal Society along with the Academy of Medicine Malaysia. Anybody, if you look at it at its average risk, whoever is walking into our clinic currently is at the average risk. Nobody is low risk or no risk. With no family history and age above 50 is considered as average risk patients. So perform IFOBT and should stop screening at the age of 75, because after 75, the risk versus the benefit is low. And if a patient who has a moderate risk or category 2, they have a family history of colorectal cancer, more than or equal to 1 first-degree relative or 1 first-degree relative and more than 1 secondary degree relative. These patients, or they have more than 3 of them must be have got colorectal cancer, and 1 of them is a first-degree relative. Then these patients should be screened earlier. Okay, if you look at it here, the colonoscopy should be performed at the age of 40 or 10 years younger than affected relative. So it's in the basic general term is if they have a patient with a family history of colorectal cancer, let's say 60, they should begin at 50. If someone developed at 50, first degree relative, we should start screening at 40. So we make it simple and always say 10 years earlier than them. So that why the 10-year frame is because from a polyp to develop into cancer, the time frame is up to 10 years. So we always go 10 years earlier. So this is something important. High-risk patients who have family history of colorectal cancer less than 50 years old, patients with syndromic like FAP, HNPCC, and all these patients should have screened at least 10 years earlier. So these are very high-risk patients or high-risk patients. So there is an update on colorectal cancer screening. In America, they have reduced it to 45. And this is because I had this presentation last year. I think that colorectal cancer in the young population, if you see it at a very alarming rate, colorectal cancer is increasing among the young patient. And I would say one of the statements that I found very disturbing also in this was paper was published, and is that people who are born 1990 and above are at over 4 times risk of developing rectal cancer and double the risk of developing colon cancer compared to people who are born in 1950. So we should be aware this younger population is going to come to us and they could be having a colorectal cancer. So this is something that was published by the American Cancer Guidelines, that the breaking news of colorectal cancer are up among 45 to 49 years old, which is less than 50 years old. And so they say that some of them put it up as 45 is the new 50 in colorectal cancer. So screening should start early, but it is not adapted in Malaysia. In Malaysian guidelines still follows at 50. Another factor that I spoke to National Cancer Society, when I wanted to present this, is that I find a disturbing thing when patients come to me and tell me they have gone for screening for colorectal cancer about 2 years ago or 1 year ago, and they find that, doctor, the CEA is always normal. So this is something that we as doctors should advise them. CEA, it is a glycoprotein produced by 90% of colorectal cancer, and it contributes to malignant characteristic of the tumor. And many patients who have low CEA or normal CEA has got colorectal cancer. So colorectal cancer diagnosis or screening by using CEA is not been adapted in any of the guidelines, I think, up to now, and it is not useful. So if they have done screening, because most of the hospitals sell screening in general, and colonoscopy is not included in their hospital screening. I am trying to include FOBT, and also colonoscopy is into this screening method, because CEA is not useful. It is mainly used for measurement of tumor response to therapy and detecting recurrence of tumor. So basically, as a surgeon, we normally use this, we take the CEA pre-op, and many times I find patients who have normal CEA, but I'm going to operate. So what happens is patients who have high CEA and we operate, these are the ones we can be, CEA can be useful, because as we go on, the guidelines say every 3 monthly we take the CEA for the first 2 years. And if there is an increase in CEA, then we are worried about tumor recurrence. So, and also response to therapy. That means if the patient has a high CEA before the cancer operation and chemotherapy or radiotherapy, it should come down. And if it's not coming down, then we are worried about missing a tumor somewhere else, or metastatic part of the tumor. So, and we also use it post-operatively to monitor for tumor recurrence. So CEA is something that we all should be aware that it is not useful for pre-op patients and not in terms of screening. So that is one of the most important part I would like to talk about, and currently I will just basically go into management of colorectal cancer. This is something that I want to make it simple, so because I think you all just want to know about this a little bit. So let's say the patient has skipped all this. We didn't screen them, or we screened them, they had cancer, or we didn't screen them, now they develop cancer. So what we do normally is pre-operatively, we would have done at least a colonoscopy and take a biopsy to confirm it's a tumor. And because there are other things that can mimic a tumor, so sometimes like SRUS also, I've had patients who they thought it was tumor. It's always, it looks like a tumor, but it's not a tumor. So we need an HPE confirmation. And then we always stage the patient. Staging, we do a CT scan and an MRI for this patient. CT scan is in generally, we do a CT scan of the thorax, abdomen, and pelvis. If you look at it, most of the colorectal cancer will metastasize to the lymph nodes, and then will go to the liver and lung. So these are the very common places. Other than that is the bone, common places. So we do a CT thorax, abdomen, and pelvis. MRI, when is it useful? In mid to low rectal cancer. So I'll be talking a little bit of MRI later. So MRI useful only in rectal cancer. And I will also be talking about neoadjuvant chemoradiotherapy, radiation. So always when patient come, we always say the patient about neoadjuvant is only useful in rectal cancer. In the mid and lower rectal cancer, what happens is if the patient present late, let's say patient has a circumferential resection margin is involved, or the patient has got lymph nodes which are locally, we cannot take it out, and this we might leave some form of the tumor when we do the operation in the pelvis. So these patients, and also patients who have a very low rectal tumor and might impede on in their sphincters, and we want to reduce the size of the tumor, we want to downstage this tumor, then we go on doing a chemo radiation. It's a sandwich therapy we do. So thereby they give the chemotherapy sandwich with the radiotherapy. And after that, we wait 8 to 10 weeks, sometimes up to 12 weeks, but most of the time it's 8 weeks and to 10 weeks. And we do another MRI again, and see whether the tumor responds to the chemoradiation, and then we go and operate this patient. So the importance of this chemoradiation in rectal cancer, especially the mid and lower rectal cancer, is that studies have found by doing neoadjuvant chemoradiotherapy, we are reducing the local recurrence from about 12% to 6%. So the local recurrence rate is lower when we give the neoadjuvant, we operate on these patients and on a time frame of 8 to 10 weeks later. So this is why you will see that patient come to you sometimes saying that I was operated, but I had chemoradiotherapy first. Compared to colon cancer, whereby we normally operate the patient and then we look at the adjuvant chemotherapy for this patient, depending on their stage. But staging, again, will be only completed when we have the histopathological confirmation, because as you know, TNM staging, the tumor, nodes, and metastatic stages of this patient. So if you look at the MRI in rectal cancer, was first investigated somewhere in 1999, become almost mandatory in planning for rectal cancer treatment. A lot of things has evolved in MRI in rectal cancer, and it's very important to do this. We are looking on not only the nodal status and also looking at the circumferential resection margin. If our circumferential resection margin is involved or near involvement of the circumferential resection margin, it's better to give them chemoradiotherapy. So it's basically we do this MRI for the planning of chemoradiotherapy. So I hope I've spoken about the preoperative planning for these patients. So of course, in preoperative planning, we would have discussed about anesthetic point of the management for these patients and the risk versus the benefit. Now that we are going for surgery, so usually we aim for curative are not resection. There's a lot of talk open versus laparoscopy, and many patients will be coming to a general practitioner with either a stoma. They might be asking the general practitioner. I had one patient who actually went to the general practitioner when I've explained, and the general practitioner called me and asked me about the stoma. Why do you need the stoma and all that? So in terms of open versus laparoscopy, we will be talking about it in a while. But in terms of stoma, there's always a temporary versus permanent stoma. If you look at it in the mid and lower rectal cancer, many of us, in many times, patient might need a covering ileostomy. So depending on how the surgery goes, was it a simple surgery, or how was the tumor? Because sometimes we do CT scan, MRI, and when we go in, we see local involvement to the lateral peritoneal wall. Sometimes the lymph nodes are there. We have to do more dissection. Surgery was difficult, especially in the male patients, obese patients. This kind of patients, sometimes we do temporary ileostomy because the mid to lower rectal cancer, the operation, the anastomosis is quite low, and the chances of leaking is higher. Why do we do this stoma? A temporary stoma is just to protect. Let's say if the patient leak, the chances of patient dying from the leak is lower. It is not that we do the stoma or the ileostomy, the patient will not leak. It will still leak, but the effect of the leak will be smaller, or it is less to the patient. So this is why sometimes the surgeons will do a temporary stoma for these patients. And this stoma can be closed as very early, up to 1 month and above, can be closed. But usually I wait for completion of chemo or radiotherapy for the patient is well before I close the stoma. Then there is also a permanent stoma. Permanent stoma is usually done for patients who have APR, abdominal perineal resection. Thereby, we have gone down all the way down and we have closed the anal hole. Thereby, this patient has got permanent stoma. Of course, nobody can question why a permanent stoma, because if we are doing the permanent stoma, that means the tumor must be very low, very big, and would have gone through chemotherapy and all that, but still the sphincter is involved or very close to the sphincter. There is no place for anastomosis down to the anus. But there are many people who are doing also coloanal anastomosis, but this has to be, I would say, a younger patient, very motivated patient with no impairment of their sphincters. So a lot of factors are involved before we actually talk about permanent stoma. So nobody will want to put a permanent stoma unless it's really, really, really absolutely necessary. In terms of surgery, we talk about open versus laparoscopy. Many studies have shown that laparoscopy is equal to open, and this is in the beginning. This is when the laparoscopy came about. As usual, anything in surgery, when new things come about, the older people who's doing the open technique, they are very good at it, and they are still good at it, and can produce equally good result with it. Will question why is laparoscopy. So at that time they had to prove that laparoscopy has to be equally as effective, and so that why many studies was done in 2004 around that region in America, the UK, and Colorectal in Europe, and they found that laparoscopy is non-inferior to open surgery. But the good thing about laparoscopy is I did come to practice when there is laparoscopy, and one of the reasons why I like doing colorectal surgery is because of the laparoscopy, that I find that these patients, if you have seen how an open surgery with a big cut there, and they lie down for a few days with a lot of pain, delayed in return to normal functions, and I find that laparoscopy had earlier return of bowel function, shorter length of stay, and fewer days of oral and IV analgesia. Sometimes you see these patients walk the next day. So that is the good thing about laparoscopy that I found. But in earlier days, conversion rate was high because as anything in surgery, if it's just the beginning, of course, the time frame of operation and the conversion rate will be high because there's always a pressure of why not do it open. And conversion was found with associated with poorer outcome and less than 5 years of disease-free survival. So another reason why most of these patients who are converted also had a poorer disease. That means they are more advanced disease. There's always involvement of something, so they had to convert. So we cannot just associate that with the laparoscopy alone. And it was non-inferior in terms of disease-free survival, overall survival, and recurrence rate. I think over the years, we have come to practice that laparoscopy is now kind of standard for many people. That by we are good at it, and especially I find that if I'm going down to the pelvis, I can see it. If you can see the sphincters, you can see the lower border of the resection, and you can see clearly instead of just putting my finger in and digging into the pelvis. So I find laparoscopy plays a lot of importance and makes life easier, although time frame of operation might be slightly longer in pelvic surgery, especially with the low colorectal cancer. So that is going both from abdominal surgery. That means open or laparoscopy. In terms of surgery, a lot of advances has been made in the transanal approach. These are the cancers which are located, I would say, up to 10 centimeters, but in the beginning, it's about 8 centimeters from the anal verge. First they came with a transanal excision. This one in very early, you can see the published papers is up to in early 1800s. They have done this, they found tumor very low down. Why not just go from down and take it instead of going from above? But this has to be early tumors. No sphincters are involved, no lateral extension. It has to be early tumors. So they did this transanal excision. They used to remove up to 8 centimeter, must be less than 3 centimeter or equal, less than 40 centimeters percent of the circumference or equal. Why? This because of the limitation of the anatomy of the rectum mainly, and the instrument at that time only permitted them to go up to certain length of the certain distance from the anal verge, and beyond that it became very difficult. Then came transanal endoscopic surgery or transanal minimally invasive surgery. They found that compared to the the previous one, which is transanal excision. This one, they basically put in a retractor and just open the anus and just take it out. But using the TEM, they have instruments like these, like TEO, which was by, this was by Karl Stoss. I've tried this before. It's a very rigid platform of operation. It's very difficult to maneuver using this thing. They found that TEM, or transanal endoscopic surgery, produces less fragmentation and more negative margin, because the other one, you just open and just cut it off. And this one, you have the cameras and everything. You are seeing like a laparoscopy, and it produces less negative margin and lead to fewer recurrences. And then using this instrument, you can go up to 17 centimeter. That's what they did with this TEO. But the TEO instrument is rigid. It's a bit more difficult to use this. Then it came to Thamis, transanal minimally invasive surgery. This is one of my favorite of doing a transanal approach, because this was published somewhere first in 2010. This uses a single port laparoscopic platform, whereby if you look at this is one of the platforms that I've used before, SEALS platform to do a transanal surgery. This one is it's kind of a gel port, and it is soft, but I would say this port is still not the best, because it is a very narrow port. You see, if you put in 3, you need 1 camera and 2 working hands. It's already very narrow, and you will hit each other. So you need different instruments sometimes, curved instruments. So this is a patient of mine, whereby I like using this applied medical gel port. This is something that if you look at it, it's bigger, but that does not mean that inside it is bigger. Inside the gel port, it's still a small thing that we can insert, but outside it is a gel port. It has bigger space for working, so it's easier. This is a tumor which is situated about 6 to 8 centimeter from the anal verge, and is dropping down. This is the instrument. This is tumor after the resection. This is after this after the suturing has been done for the tumor. So this is a tumor that can be removed transanally, and even this was a 28-year-old patient, young patient, who was advised to do anterior resection. That means you're going from abdominal and resecting that part of the bowel and doing anastomosis. And he was worried about when he was explained about erectile dysfunction, because of course, you know, there is a risk of injuring the nerve and erectile dysfunction, and he was a young patient, so was operated this way and was removed completely. So in future, but it's already there, it is not a future, this is a flex robotic system, but robotics has come into play in colorectal cancer surgeries. Expensive, but I would say for me personally, robotic system is very useful if you're going down to the pelvis. I have done robotics before, and it's very useful in the pelvic. If you go there with a 3D view and with the robotic arms, a lot of maneuvering can be done. So, but it requires a lot of learning, and it's expensive. Then came transanal TME. Transanal TME has been in place for a few years now, but it's not been widely adapted in Malaysia yet. As usual, we go slow on it. Many people are doing it in overseas. I have trained last time with Professor Ito Masaki. He's one of the people who does this. The problem with laparoscopic TME is that it has limitation in mid and low rectal cancer. So thereby, in the mid to low rectal cancer, the problem that they find that you cannot see the lower border. So why not approach from below? This is when transanal TME coming about right now. So thereby, it's a bottom-up approach, and sometimes they combine laparoscopic TME. LATME is a laparoscopic TME combined with a transanal TME. And there's also a pure TAR-TME, which is still new in Malaysia. And then there is also a single incision laparoscopic surgery. Theoretically, it is less pain, earlier discharge, and cosmetically better. I would say most of the time I feel I've done this before and it is for cosmetically better. Earlier discharge, yes, but less pain, it is subjective. Some papers look at it and say it's less pain. Some people will say it is more pain. But in general and in reality, it needs a lot of training because of the lack of the triangulation and a limited space to manipulate the instrument. And you need a curved instrument if you're not used to doing with a straight instrument. It's become more difficult with a straight instrument. But with a curved instrument, you have to train. So this is how multi-port surgery that we normally do. And sometimes some people put one more port up here. And this is how people do multi-port channel single incision laparoscopic surgery. But there are also people who do SILS plus one, another one here. SILS is a comparison of single incision laparoscopic high anterior with standard laparoscopic. They found that operating time was significantly shorter in SILS surgery. But I would not agree to this because as I tried this and I've done this before, the operating time is slightly or significantly longer, especially in the earlier part. The learning curve is higher. The difficulty with the straight instrument compared to the curved instrument, or when you're using the curved instrument, you need time to learn. But the discharge would be faster in terms of cosmetically better. This is another systematic review of single incision laparoscopic colorectal surgery. The evidence again for reduction of postoperative pain is conflicting. Like I said before, single incision laparoscopic colectomy for colorectal cancer compared to conventional laparoscopic colectomy. So this one, I completely agree. Operating time, like anything in surgery, the more you do, the more better you become, and the time frame will become shorter. This is one of my patients. This is a single port that was done single incision. This is how you will look once the gas is insufflated. And this is the scar. If you look at it, previously, this scar would have been somewhere from here to here open. And if you're doing a multi-port incision, here, here, and here, here. But this one, you can hide it all in the umbilicus. And when this patient come about 3 to 6 months later, even this will go into the umbilicus and you cannot see this patient has been operated for cancer. This is important for many patients, especially female, especially young patients. So, but it depends who can be done. It has to be early tumor, not big tumor, not late. There's no lateral invasions. So these kind of patients, we can try this. So I think I will conclude my part 2 on my presentation today. So the take-home message on this part 2 is that one of the most important things I want to say is screening saves lives. Colonoscopy is still the gold standard, but of course, many patients who are at very low risk or at average risk, please go ahead and do some form of screening like fecal or cut blood test, and have a very low threshold for these patients. Don't think young patients cannot get, or they are just having diarrhea, or they're just having per-rectal bleeding because of hemorrhoids. So per-rectal bleeding is not normal. It's something that we all should investigate. It could be because of the hemorrhoid. If there is nothing inside, I always tell the patient, if there's nothing inside, it's well and good. So at least you and me are talking about something benign. We're not talking about something more malignant sitting down inside. And please be aware of CEA as screening. It is not useful. CEA is only useful for post-operative patients who had a high CEA in the beginning. Then we are monitoring these patients. There's a lot of technological advancement in colorectal cancer surgery, and it's still evolving. We are all still learning in certain aspect of colorectal cancer surgery. So I think over the years, there will be still advancement coming along the way, like robotics. And I do not know what after robots, maybe flex robot, And after that, another robot might just come, or AI, all this where doctor don't have to be involved anymore. So thank you very much. I hope I made some good presentation here, and hopefully Dr. Murali can highlight you all from now. Thank you so much.
Thank you so much, Doctor. I'm hoping I can be heard this time around.
Yes, yes.
Oh, wonderful. Okay, thank you so much for that very enlightening presentation, Doc. I'm aware that you're always quite, how to say, super busy, but I'm just wondering if I can tarik a little bit of time in terms of questions.
Yes, yes.
Lovely. Doc, there's one question, I think, from one of our colleagues on screening for an average risk patient should be from about 50 to 75. Is that right?
Yes, yes.
Okay, but however, just keeping in point, however, that you did speak today about looking at your earlier younger patients as well.
Yes, screening, I would say nowadays it should start about 45. This is my own perception, because I see more and more cancer patient coming at an earlier age. So I feel that anyone who has the means for it should be screened as early as possible. Of course, you don't go catch a 20-year-old, 30-year-old, at least 40-year-old to go and screen. But American Cancer Guideline in America, they have reduced it to 45. But we still adopt for 50 is because of the cost versus the benefit of screening, and the number of detection is low. So thereby, we're still sticking in Malaysian guideline to 50 years old. So I would say, go ahead. If the younger patient has got symptoms, please send them over.
Okay. Will do, Doc. Doc, so this is in terms of to our colleagues in primary care. Is it when, okay, this is, I'm trying to pick your brain on how would be a better messaging for them to tell their patients. It's, as you know, as a startup, the IFOBT is sometimes very difficult to get people to do. Any tips on how you can advise your patients to, encourage them to get on board first, at least to do an IFBT annually, and then subsequently, go on to do a colonoscopy?
Yeah, I in my clinic, when the patient come and they are 50 years and above, I always ask them, have you done any form of screening? And I always explain to them why you should be screened. I always tell them, this is polyp. I have a picture at the back of my, at the back of me. So I always show them, this is polyp, and this polyp takes about 10 years to grow. And if I can catch this polyp at this so small, I will just tube it. I always say, I just pick it and throw it. I don't throw it, I'll send it to the lab. So if you have this big cancer, if you miss this 10-year period that we have, and you develop into cancer, I always have to operate your colon. I have to cut you. I have to do big surgery. And why do you want to do that? So I always say FOBT is non-painful. It's just you go, you take the sample, you can go home also and bring it back. So it is a non-invasive test. It's a very simple test, and it can be done easily. So at least do FOBT. That's what I always tell my patients if they are not keen for colonoscopy.
Okay. Will do, Doc. And I think more so than getting those unkeen for colonoscopy, I think, as you were mentioning earlier, it needs to be a behavior kind of consistency. So as much as everyone, the good thing is people are now used to going and doing an annual medical checkup. But now what constitutes the medical checkup is now where you want to kind of put in this idea of whatever of an IFOBT kind of.
Yes, because I see even in many hospitals, there is a lot of screening going on.
Right.
They do medical screening, medical checkup. In their medical checkup, they always include a CEA as a cancer marker. Right? So the same thing, hospital is selling that, and when the patient has done that and they come to me and I talk about colorectal cancer, they say, Doctor, I just did a colorectal cancer marker. I have already done it. I'm very sure I got no colorectal cancer. So this is something that it's worrying. Then I always tell them, okay, this one we do not use for colorectal cancer screening. It is not in any guideline yet. So we use this only for post-operation. We use it as a method to detect recurrence or the response to treatment. So that's why even my hospital, I am trying to include IFOBT into screening. So if they are 50 and above, if they are screening, why not? Just put this, and it just costs a few hundred extra. I think it's about 100 plus extra in the private. I'm not sure in the government they will adopt this.
Right, right, absolutely, Doc. Next, Doc, I wanted to ask you. There's a question from colleagues now about a baseline colonoscope. And what are your thoughts on this? Somebody is turning 45. Is it what kind of messaging maybe you can share with our colleagues on? First, do you think it's warranted? Every 50,000 I go do a major service for my car, that kind of idea. At 45, should I get a baseline colonoscope even if I have nothing? And if so, what kind of messaging can I use to kind of discuss to my patients on getting them, convincing them?
Yeah, it's very difficult to convince anyone for an invasive procedure, I would say, right? If they have no symptoms and they have no family history of colorectal cancer, they have no symptoms whatsoever, they have no constipation, they have no rectal bleeding, there is no abdominal pain. These are very difficult to convince this patient. But I would say at least these patients should be screened at 50, and I'll always tell them, what is a colonoscopy? A colonoscopy is an invasive but with a very low risk of perforations or bleeding. So I'll always tell them, at least you do one colonoscopy, you're safe for 10 years. Mm-hmm. That means you have done it, you have no polyp, you had a good bowel prep. I viewed about at least 95% to 100% of your mucosa. That means you have a very low risk. That means for 10 years, you are quite sure that you will not develop colorectal cancer. So some patients, when we say, that time frame that we give, one, we have done colonoscopy, they will say, well and good, I'll do one, next 10 years, I'll see you again. So instead, if I tell them, I do FOBT, you have to do yearly, you have to come back again, and there is still chances of missing a polyp or cancer inside. So, of course, they would say colonoscopy is better. But some patients who are worried, or some patients with no risk at all, and just for screening purpose, they will say, okay, doctor, I will do FOBT first. I will do for yearly.
Right. Doc, I think we have one or two more questions. I had a very interesting question to share with you and ask your opinion on. Doc, we know that colorectal cancer is almost one of the highest cancers within the country today, which really means for a lot of our patients, when they do come to us in primary care, ostensibly one of their family members or somebody who has a blood relation, as you were saying earlier, is someone with colorectal cancer. Is it worth, do you think, for our colleagues in primary care to kind of have it consciously at the top of my mind to ask this question, hey, has anyone in your family suffering from this? Should then this become a kind of progressive line for them to actually get screened as well?
Yeah, definitely. Although the colorectal cancer, the familial or genetics is low, but you will find many patients sporadically have developed this colorectal cancer in current time, and either one or another of their family is always had a colorectal cancer. So but I always ask them, is their first degree relative or second degree relative ever had a cancer colon? If they have a cancer breast, if they have endometrial cancer, if they have related urinary tract cancer. So I'll always ask this question. And if they have had, then I'll always ask them whether you have any bowel symptoms. If you have bowel symptoms, that even more so, they should be screened, or they should have some form of investigation done for them. But if they don't have, and they fall into the category whereby they are at average risk and they are 50 years and more, I'll always suggest to them to do some form of screening, and it's important that we advise them.
Right. Doc, this is another interesting question from a colleague. Does hemorrhoids cause an IFOBT to become positive?
Of course, you can, if a hemorrhoid is bleeding, definitely can cause IFOBT to become positive. This is something, an important question, I think, is that many patients who come to me with rectal bleeding. All right, when I'll tell you what happens in my clinic. I do a proctoscopy and I don't see the bleeding. So that is a very, very common for hemorrhoid. You cannot see, this is a bleeding that we can be seen. I'm not talking about occult blood. So when they come to my clinic, I put in a proctoscopy, I don't see any more bleeding. So now, Do I assume this bleed could have been caused by hemorrhoid, or I have to investigate the patients? If you ask me, in year 2022, with the current medical legal risk and the number of cancers that is increasing so much, I would assume this could be something else. I'll always tell the patient, it's better to investigate and put in a colonoscopy and just have a look once. If you don't have anything, well and good. I'm happy you're happy. If your hemorrhoid comes back and bleed, I will say it's either you take medication or you want to go for surgery. So in my opinion, if you don't want surgery also, you just take the medication as long as you want. Because I've done your colonoscopy, I'm not worried I'm missing a cancer. So it makes everybody's life simple, isn't it? Of course, the small negligent risk that we are talking about could happen anytime. I hope it doesn't happen to any one of us colleagues. But in terms of perforation or bleeding when you do a colonoscopy, but still, it is something that makes the patient also better. You know, because most of these patients, when they have per-rectal bleeding, they have something in their mind. Oh, could it be cancer? But they will always say, oh, it's just an hemorrhoid. But it's still at the back of their mind, it could be cancer. So let me settle it once and for all for you. So that's what I'll tell them. If it's not there, it's good.
Right. Absolutely. Absolutely. So, Doc, as we are beyond the top of the hour, and I think we have completed all the questions that our colleagues may have put on forward. I'll just leave it another 30 seconds to see whether there's anybody who's asking anything. But as we wrap up the session, Doc, first, thank you so much again for doing this on a Sunday. And
thank you so much, and sorry for the delays.
Absolutely no problem. I think as we started, we said, look, every day is colorectal day.
Yes,
it's not only March.
Important. We are just shouting around in March, but we hope it is throughout the year.
Yep, absolutely. So, and as we wrap up, Doc, any kind of last kind of words of wisdom that you can share with us on us taking home to our practices?
Yeah, one of the most important things that we must all be aware in year 2022 and beyond, that colorectal cancer is going to increase more. That not only the older population, also in the younger population. We as a clinician should be aware and have a very low threshold to investigate this patient, be it non-invasive, be it invasive, in some way or another, to at least advise this patient and document that we have advised these patients to get some form of screening or some form of investigation to be done in terms of investigating the colorectal cancer. Of course, there's a lot of other causes for per-rectal bleeding, abdominal pains, or whatever symptoms of colorectal cancer, and we do not want them to have the symptom when we do something. Because when we treat them early, it's not only good for the patient, it's also good for the country, because I feel that the cost of treatment at the higher stage is much more expensive, and the quality of life is much more less. And the patient suffering is it's a lot more compared to what I see when we just do a colonoscopy. They just come out in 20 minutes and they're okay.
Right.
So please be aware of this, and let's all try to do something about this.
Okay, will do. Doc, thank you so much. Thank you so much, ladies and gentlemen, for
thank
joining
you for
us.
the National Cancer Society of Malaysia for inviting me. It's been a pleasure to be with you all.
Always. Ladies and gentlemen, this was Dr. Ragu Ramasamy, Consultant General and Colorectal Surgeon from Avisena Hospital and Subanjaya Medical Center. And he spoke to us this morning about colorectal cancer awareness. Please feel free to reach out to him or us with any questions so that we can help field them. And as usual, you need to put in your documentation for you to get your points. Thank you very much for joining us. For those of our colleagues who will be starting the fasting month, Ramadan Kareem. Hope you have a very fruitful and very spiritual fasting month. And let's get back on track. Thank you very much. Have a nice weekend.
Thank you. See you all.